Welcome to The Point of View. This is your favorite current affairs show here on Channel 1 Television. Here on The Point of View, we get the right guests. We ask them relevant questions on issues that matter to you. We have a big guest tonight. He's the Minister for Health and MP for the Dwabusu Constituency, and he's going to be talking about everything. Recruitment of health professionals, revamping the health infrastructure, payments for health insurance, and capping the health insurance fund, and his style of leadership, which goes to the people to deliver health care. All of that and more live tonight. Send us your questions and your comments as Kwabena Mintah Akandoh joins us when we come back.
Uncle are almost here.
Wait a minute. This one too, your friend Kwame.
Wait, Kwame. As in the same Kwame again?
Yes, Mommy.
I'm the second coming. Into all this tension just to reintroduce that broke boy from Kaswa.
Why would you deceive the family like this again?
Now I understand the whole delay. Troll from Kaswa. Why wouldn't he be late? Or be late?
Of course.
Start 712 hash, start 712 hash. Yeah, you go be the luckiest. Go be from Georgia, be luckiest. From not the Pia, cause she be luckiest. Me and you go be luckiest. No matter why you're lucky, everybody go be the luckiest.
That's Kwame!
Send your God down for boom. If you're poor, what's that? So would the coming of the son of man be. Is that his car?
Dial star 712 hash. Choose your ticket. Enter your lucky number. Follow the prompts and let destiny handle the rest.
This promotion is regulated by the NLA on the Caritas platform.
So we're live tonight with Kwabena Mintah Akandoh. He's the Minister for Health. He's been in the news. It's a busy period. Indeed, health and education have been in the news, I think, for the past 2 weeks because lots of people who have been trained could not be employed. The Minister for Education gave some assurances. The Minister for Health gave some assurances. The Minister for Finance gave assurances. So it's like a very important season for professionals within those two key sectors. There's also a lot being said about health infrastructure in the country. There are concerns around the quality of health service delivery and issues around retooling of our health facilities. And of course, we'll also talk about the good old National Health Insurance Scheme. Kwabena Mintah Akandoh, good evening.
Good evening, my brother.
How are you doing?
By the grace of God.
You were the ranking member for health, so it looks like the president's equation was, if you serve as ranking, I'll give you the position. So I think Roads Minister did the same, Finance was the same. I think you too, you were in that category. I'm not sure if he told you, he didn't mention your work in opposition as part of the reason why he was giving you this role.
Not at all.
He did not.
As far as I'm concerned, I do not know why His Excellency the President thinks that I should be the best person to be in the ministry. So he didn't give you that. He didn't give you that
background. But how long were you on the health committee in?
I was the ranking member on the health committee for 7 years.
Which means 2 parliaments.
Yes. So. From 2016 to 2017, Honorable Yerichire was a ranking on the health committee. So I took over from Honorable Yerichire around 2018.
Okay.
So
wow. So the 2021 parliament, you were still ranking member?
Yes, I was still ranking member.
How did that happen? Because I know you're a farmer. I know you did statistics. So how did you end up on the health committee? Where did you get interested in health?
Well, that's a very interesting question. You know, when I came to Parliament in 2016, after the 2016 election, I was made a deputy ranking on lands and natural resources. So at a point in time, the leadership of Parliament called me and they say they want to take me to the health committee. So about 2 weeks discussion, and then at the end of the day, they came to a consensus that there's something they want me to go and do on the committee. And so it was a lengthy discussion. At the point in time, people thought that I should go to the Committee on Cocoa Affairs and the Agric and all that. But at the end of the day, given the architecture of Parliament at the time and the leadership, they thought that I could play that role.
How critical is the health committee to the work of a minister?
The health committee actually plays the oversight responsibility on the health sector in the whole country.
So essentially, most of the policy implementation of the minister,
so
the committee would know.
Whether it is the airlines or the bills or everything health in the country goes to the health committee.
Interesting. It looked like when you were the ranking on that committee, you developed this approach of visiting facilities and showing what was there. I think a few media reports did that. In fact, some of my members' media team followed you. You would go to a hospital which was either not finished or there was something wrong, and then you would speak. That seems to have been your style. And some people think you've continued that style as minister. Is that correct?
Yeah. Bernard, I am not the type who always want to sit at one place and work. I'm a grassroots person, and so I will always want to go to the grounds and familiarize myself to have first-hand information. And for me, that will inform decision-making. You know, you interact with the people, you know what the people are going through. And for example, if you pay unannounced visit, you get to know the realities on the ground than giving notice that you are coming, so that people may even do the writing and you may not see the reality on the ground. So for me, that has been my style. I will always want to go to the grounds, and then that has also helped me to take certain decisions that are very popular with the people.
So it's not something you regret doing, the fact that you show up unannounced at a facility?
I have never regretted, and I'll continue to
do it.
Yeah.
Some people think that as minister, it may not be the best because, you know, as opposition, going to a facility to show what is not working may be good because the public wants things to be solved. But as minister, as the duty bearer, when you go there, it's like you are shaming your staff. It's like you appear somewhere and then you are like, what's happening? Why is this not here? What's going on here? It presents a picture of you trying to catch them, which is why a lot of people have criticized it.
Everybody and his style, you understand? The intention is not to expose anybody per se.
Okay.
The intention is for me to know the realities on the ground.
All right.
You understand? Because we have done certain things in a particular manner that hasn't given us the desired results. I am of the view that sometimes if as a minister you sit in the office and send people to the grounds to bring you a report, you may not know the realities on the ground.
Okay.
So I would like to go to the grounds, and I want everybody, every health professional to feel that, look, irrespective of where you are, you can see the minister at any given time.
Okay.
You are not too far from the minister. So it's my style, and I don't regret doing that, and I'll continue to do it.
Let me just do two things on that before we come to the issues on recruitment. I think the first major story, high-profile story that your name was associated with was the Tamale Teaching Hospital incident, where you went there, and for some reason, the medical professionals, they got upset about something you said and decided they weren't going to work anymore. Why did you go there? And can you explain because you went with the MP for the Tamale North. What was the urgency of going there physically?
Good. Bernard, a night to the day I went there, I picked information that one young guy had lost his life. And so there was agitation building up in the media, especially on social media. And that was the time I was doing this unannounced visit. So at dawn, I decided to, because the information I picked was that the youth were massing up to attack the health professionals at Tamale Teaching Hospital.
Really?
Yes. They were very angry as to how that particular boy was handled. And at the end of the day, we even lost that boy. And so that morning, I took the first flight to Tamale.
Okay.
And then when I arrived, I called the CEO for the facility, and then I told him, yes, I'm here and I want to see what is happening. So he started conducting me around. So we went round and I saw some of the things that were not very pleasant, and we had a lengthy chat and conversation. And we even had behind the scene meeting, try to draw their attention to some of the things I had seen, and they were not in order. So we went to the emergency unit. I started asking them, probing into the incident. And then they told me the incident was around having mobile ventilators and what have you. But the story had it that after the time the patient arrived, there were some empty beds. So at that point, the media was not with us. So I asked, so why were there empty beds and yet you couldn't bring that patient to the emergency unit? And they said, well, at the time, another patient had rang that he was coming by the ambulance. And so they didn't want to occupy that bed so that when that one who they were expecting comes, they will not have any place for him. And so I advised them. Then we went down there and I met this gentleman, a medical doctor, trying to take me through the processes. But at the point in time, he was very upset. So I took my time listening to him. So he was screaming on top of his voice. And so,
upset at you?
Yes. I mean, at that point, his body posture and everything, and there were a lot of people around. The cameras were, the media men, everybody were following us. So after the explanation, I decided to continue my round. But I heard him still talking at the back and screaming on top of his voice. So then I dashed back. And I said, gentlemen.
How many of you, were you there with the MP?
I was there with the MP.
I see.
I was there with the MP. One of the statements he made and the MP got angry was that, why is it that this issue has been blown out of proportion? And so the MP said,
so this is Alasan Suhini?
Suhini. The MP said, a whole human being is dead, and you don't understand why it's been blown out of proportion? You understand? And so I dashed back to him. I said, if you can talk to the minister this way, then I can imagine what you do to the patients here. So at that point, when I was dashing back to him to tell him, because we had concluded the conversation, I was walking away and he was still talking. That was where the media captured it and then they were circulating everything everywhere. But wow. I thought it's part of the...
So when the health workers said they were not going to work until you apologized, you were
there was no need for an apology anyway.
You were taken aback by the... Was it the reportage that got them angry or what they saw there?
Well, I was actually surprised about what could cause anybody angry. Because if anything at all, I thought that the leadership there would have also been worried about the way and manner the medical doctor spoke to his minister. It's not the Kwabena Mintah in person I'm talking about. But whether you like it or not, at that point in time, you had met your minister. Respect is supposed to be reciprocal, you understand? And so I was actually taken aback as to why anybody would think that it is the minister rather who should apologize. Okay. When at the glare view of everybody, it is rather the medical doctor who had disrespected the minister, you know. So they came, we sat down, the Ghana Medical Association leadership came, we sat down, I explained it to them, and they said they needed some equipment. We mobilized and gave it to them, and then
it was
let bygones. Yeah.
And of course, there was also the Ridge Hospital, Ralph and his... I'm told for both events, you commissioned the report.
Yes, so we have a report that we are implementing at the moment. So the Ralph one too, as you recall, allegedly there was some kind of delay in attending to a patient, and then Ralph showed up. Apparently, Ralph was also seeking some medical attention. So according to him, there was some delay. And so they felt threatened at the time because according to the health professionals, Ralph had organized some people to come and attack them. So in that morning, I sent a delegation to the hospital, for some information for me. And then when they came back, they said the nurses were very apprehensive and they were not comfortable and they were even considering going home and all that. And you know, Ridge is not too far from the ministry. So I decided to walk and then go and talk to them to reassure them.
Okay.
So I went there. So after talking to them, we had a closed door meeting to try to tease out the issues that caused that and all that. After addressing them and I was coming out, this gentleman, Ralph, pulled out and then stretched his hands to greet me and trying to whisper something into my ears. I greeted him. In fact, I didn't even know him.
Oh, you didn't know who he was?
I didn't even know in the initial. So it was my officers who drew my attention that was Ralph.
I see.
Okay. So
people were angry that you were shaking his hand when he had assaulted the nurse allegedly, and then the minister was caught being cozy with him. So you didn't know who he was?
No, as at the time I was greeting him, I was stretching my hand, I knew. But as at the time he was approaching me, I didn't even know who he was.
I see.
Yes. So I greeted him and later commissioned the inquiry.
So have you made any changes to Tamale or Ridge on the basis of those two incidents? Has anything, what was the most important thing that has changed in those two hospitals?
Well, in Tamale, for example, we gave them a number of equipment, more than, if I can remember, more than 2 million worth of medical equipment. Ridge 2, we have beefed up the security there. Even Ridge, we have not finished implementing the recommendation. We are still implementing the recommendation.
I see. Let's deal with the issue on the first issue. The minority held a press conference, I think, a day or two ago. I think Dr. Uefree addressed the press. I just wanted to play a few of the things he said for your reaction. So, guys, if you have the Dr. Uefree video ready, I think I can add. He addressed a number of issues. Chronicle had a very interesting front page. It says, Massa, stop the tobe and employ the people. That was Chronicle's front page interpretation of what a Uefree said. So let's hear a Uefree and I will take your reaction.
In normal public administration and civil service of this country, financial clearances expire. Even under this government, they will have financial clearances expire and they will go for extension. It is a normal practice in the system. It's no news, but you could only use it when you go for an extension for the Ministry of Finance. So why didn't government see the need? Money was allocated for 15,000. You came in 7,000 or almost 8,000 had started. The remaining were employed by Ghana Health Service, albeit they were late, but they were at post. You didn't see the need to tell the institutions to reject them. Neither did the institutions write to you to reject them. What it meant was that they filled the gap and they were needed to be at post. So the institution used them, except for political reasons. They did not extend this for political reasons. And then 10 months down, they faced an embarrassment where the students or the staff went on a public agitation demonstration to draw your mind to this clearance and the need for extension. Embarrassing enough, you are saying that you've taken it to cabinet for an approval. What sort of cabinet do you have to take for an approval when you have a clearance already? You're throwing that in the eyes of the people. So government created a mess. And they've seen 10 months, it's caught up on them and they are fixing it.
So that was Dr. Uefree. I think you should respond directly to what he said. He doesn't understand why you're even going to cabinet. He says it's a mess you've created and you are fixing it and you are using cabinet as an excuse. What's your response?
So, Bernard, the reality is that in 2024, government started to recruit nurses and midwives. So the summary is that they recruited about 13,500 nurses and midwives and issued clearance.
Okay.
Once you issue clearance, you must make financial provision. Clearance is just not a paper. It's not just like you can issue clearance at any given time. You must issue clearance when indeed you can pay, when you recruit the people. So they issued the clearance and the clearance expired on 31st December 2024. What it means is that before the expiration of the clearance, you must necessarily have all these 13,500 people on the payroll.
Okay.
As at the end of the 31st December 2024, not a single one of the 13,500 people were on the payroll.
These 13,500, when were they recruited?
They were recruited in 2024. They started around August, thereabout.
And they were given clearance.
And they were given clearance.
Not paid.
But they were given clearance, but
financial provision was not made.
Was not made. Do you understand? So when this expired, we took office in 2025 January. So when we came, there were two options available. Because there were no allocation for these, nurses and midwives. So we had two. It was not as though they had put them on the payroll and we came and we said we won't pay them. That is not the situation. So there were two options available. One, let them go home and look for the funding and extend the clearance, and then they come and work. Two, you can allow them to work whilst you look at how you pay them. Because that was not captured as part of our budget.
Because your minister did his budget in March. So are you saying that even though the previous government hadn't made provision for these guys, the first budget was read by Atu?
It was also not captured at all.
Why didn't Atu put the 13,500 in his budget for 2025 March? Is it that he didn't know that they had been recruited and then cleared and clearance had expired?
You know, there were a lot of things. You see, during transition period, you get the reports, and based on the report, you do your budget. And in most cases, they were not in the handing over notes at all.
I see.
So as you go along, you try to unravel some of these things. Do you understand? And so as at the time I took over, and I took over around February, later part of February. You understand? And so as at the time we came, there were no allocation whatsoever to the 13,500 people. So we decided that, okay, no matter what they've been recruited, so let them stay, and let's try to put them on the payroll. We make some adjustment. So I have been collaborating with the minister responsible for finance, and out of the 13,500, it's not as though we went to sleep. We managed to put about 7,000 of them on the
That's about half of them.
That's about half of them. So half of them were being paid. In fact, the reality is that we captured about 10,000 of them on the payroll, but only 7,000 on the payroll were being paid.
As of which period? When did you start paying them?
Oh, that's as at the time. That's about. Some of them have received payment from March thereabout.
I see.
As at the time we realized that there was.
These are the 2024 recruited, financially cleared, but no provision made for.
Not even the financial clearance expired. So as at the time we inherited, there was no extension.
So you are saying that from March 2025, you managed to pay you started paying about 7,000 of them.
So we were, onboarding them gradually.
Okay.
Okay, we were onboarding them gradually. So it got to a time that we realized that there were a lot of things, more than even the 13,500 nurses they had recruited. There were arrears of, allowances. There were, conditions of service that had been signed and they were not implemented. There were housemanship from 2023 to 2024 that were also arrears, especially the pharmacist people. We had to pay. So it was like the budget was becoming
much bigger.
So, and if at the point that we realized that if we don't go back to cabinet to take a decision on it, it will throw the budget off.
So you're saying you had to go to cabinet because the number of nurses who were to be employed from 2024 was larger than you knew from the handing over?
From the handing over. Right from the handing over.
Good. I'll take a break. When I come back, I'll go back to something. I interviewed the Deputy Finance Minister on Thursday or so last week, and he said there were 75,000 health professionals who needed to be put on the payroll at the cost of 6 billion cedis. Do you have a breakdown of that?
Yeah, we have it. I think.
Okay, when we come back, I'll let you talk me through that. 75,000.
It's around 74,000.
Health professionals.
Health professionals who has been trained, pharmacists, nurses.
Trained from which year?
From the nurses, for example, we have backlog from 2021.
Wow.
What we are discussing now is a 2020 bar.
Wow.
So we have 2021 at home, 2024 at home, 2024 at home, 2023 at home.
74?
In some cases, from even 2019 till date.
You are serious?
Yes. So
2019?
Yes, you check.
Before COVID?
You will see it.
75,000?
These are some of the things we have inherited.
I'll take a break.
And we are cleaning it gradually.
I'll take a break. We're talking to Health Minister Kwabena Mintah Akandoh. You can send your questions as well. We're trying to understand and break down this perennial issue of recruitment, nurses, medical professionals asking to be employed. Stay with us.
Introducing Ghana's first unlimited photocopier leasing. Yes, from just 983 Ghana cedis, you can lease a multifunctional photocopier and print unlimited. Yes, unlimited and free paper every month. Guess what? That's not all. Toners, repairs, and maintenance all are free. And oh, I'm not kidding at all. And we cover the whole country. Yes, the whole country. What are you waiting for? Just visit us at www.valexlease.com or call 0244 644048. Remember, terms and conditions apply. Valex Lease, affordable document management solutions.
Kwame and his uncle are almost here.
Wait a minute. This one too, your friend Kwame.
Wait, Kwame. As in the same Kwame again?
Yes, mommy.
The second coming. Into all this tension just to reintroduce that broke boy from Kaswa.
Why would you deceive the family like this again?
Now I understand the whole delay. Troll from Kaswa. Why wouldn't he be late? Or be late, of course.
Star 712 hash, star 712 hash. You go be the luckiest. Coffee from Georgia be luckiest. From not the pure cause she be luckiest. Yeah, you go be luckiest. No matter why you're lucky. Everybody go be the luckiest.
That's Kwame!
Send your God the apple boom. If you put it toye, so would the coming of the son of man be. Is that his car?
Dial star 712 hash. Choose your ticket. Enter your lucky number. Follow the prompts and let destiny handle the rest.
This promotion is regulated by the NLA on the Caritas platform.
We're speaking to Kwabena Mintah Akandoh, Health Minister, trying to understand the agitations from the health sector. He held a press conference a couple of days ago announcing that a number of health professionals who had not been put on payroll will be put on payroll from November. The minority says he didn't need to have gone to say anything about cabinet. This is something they should have just done. I wanted you to show me a couple of things. You said when you took over, there were 13,500 nurses
recruited.
Who had been recruited.
Yes, and no financial provision was made.
And that you started?
And then, let me make this point. You know, if, health professionals are recruited and you are given the budget, the compensation, you don't need to go to Parliament or Cabinet or even a finance ministry. But if you don't have it as a ministry, Ministry of Health, you always have to collaborate with the Ministry of Finance. And if it's above the Ministry of Finance, we go to Cabinet.
Okay.
So the money doesn't sit with the ministry. If it sits with the ministry, you don't need to go.
So because allocation had not been made, you had to go and argue in
Cabinet for the allocation.
You said you had money to pay 7,000 or so.
Yes.
Do you have the breakdown of that whole situation? You said
Yes.
13,000 recruited.
Yes.
And they were not being paid, and you managed to pay about half of them.
Yes. So we have how many were captured on the payroll.
Do you have that information here?
Yes, I have it.
Yeah. Where is it? Is it this one?
Yes, this one. Yeah.
Can you explain what this is?
Yes. So if you check the table, total clearance issued. They issued clearance to recruit about 15,200.
This is before they left power?
Before they left
MPP.
power.
Okay.
And then they actually recruited 13,500. Okay. Now, out of the 13,000, when we realized that this is what we have, we either have to let them go home or... So we captured about 10,315 on the payroll, Controller Accountant General.
When?
That was around after March. You understand? And so on that same figure, the number 10,000 that has been captured, about 7,239 are being paid.
From which period? From March?
From March, thereabout. Then you see the figure is 10,000, that is on the payroll. So there's about 3,076 that are on the payroll, but they are not being paid. if you check the figure, 13,500, 10,000 on the, so there's another figure that has not been captured at all, 3,000.
So you can say about 6,000
exactly.
were not being paid.
At all.
Some not captured, some captured.
Exactly. So this is what we currently...
When you say captured by controller, what does it mean?
If I don't know how you want to just...
No, so if
I want
to understand. It means, is it that controller doesn't think they are nurses and therefore he won't pay them, or he has not finished the process of putting them
No,
in
you see,
system?
before you even initiate any payment from controller, it must go through a process. Okay? So we went through a process, but then, even if they are on the payroll at the controller, you need certain documentations like the financial clearance and then hologram. So if the finance ministry doesn't issue the financial clearance and the hologram, although they could be on the controller's list, but they can even cease payment.
I see.
Do you understand it now? And so there were about 3,185 which were not on the payroll at all.
Have you, based on your announcement yesterday, put these people on the payroll now?
So a letter has been issued from the Ministry of Finance that they'll begin to pay them from November.
So it means that by November, all these 13,500
exactly
people will be paid. Good.
So it is not, let's make the point, it is not as though they made financial provision, they were on the payroll, they were being paid, and we stopped it.
Fair enough. Somebody said government is a continuum.
I agree.
So you came to power to
solve
no
problems. Lamentation, solution. I agree. But you see, when the very person...
So by the way, the November they will be paid. Had they been working from January?
Yes, they've been working for...
So even though they were not captured or their clearance had expired, they were still working?
Yes, so there will be...
So are you paying them their backlog?
Yes, so there will be a schedule for...
Or back pay, as they call it?
Yes, there will be some arrangement for the payment of the backlog. But then from November, all the 13,000 will be paid. Then government will...
Because you know that they can also... I've seen before people complain about their back pay not being paid.
Yeah, we will pay.
So from November, you are paying them November salary?
We'll have an arrangement. From November, we'll pay the November salary. And then we'll tell them, we'll communicate how we are going to stagger the payment.
Deputy Minister for Finance said that 74,000 health professionals are waiting to be employed by government. Yeah. And you say it's correct. Do you have a breakdown
of that? Yes, I have the breakdown. And we will need not less than 6 billion
6 billion
Ghana cedis to be able to absorb all the 74,000 health professionals at home at the moment.
Are you serious?
So
explain this to me.
So this is what we inherited. Medical doctors, the 2024 batch, who had finished their housemanship and they are at home, were around 942.
So 2024 batch, 942 medical doctors.
Very good.
They had finished housemanship, ready to be full doctors.
Doctors to go to the various hospitals.
942.
By the grace of God, we've been able to, recruit them. We've had clearance for them, and now, very soon, they are going to start work. So this has been sorted. Now, allied health professionals, the last time they did recruitment for allied health professionals were somewhere in 2018. So from 2019 to 2024, we have about 19,000 backlog at home.
Are you saying they had not employed any of them? These were the ones who could not get employed?
No, they had not. They had not employed any of them.
Are you serious?
Yes.
19,000 allied health professionals?
Yes.
Who is an allied health professional? Like what? Lab technicians?
Exactly.
Those kind of people?
Exactly.
19,000?
Yes. So we have pharmacy doctors. About from 2019 to 2024, we have about 800 of them at home.
Wow.
We have pharmacy professionals, about 500 at home, nurses and midwives. So if you go to the nurses and midwives, the 2021 batch, they are at home. They are about 15,000.
2021, those who were ready to work 2021?
Yes. And then 2022, they are about 17,000.
All sitting at home?
Sitting at home. 2023, they are about 15,000. Physician assistant, they are about 3,000. So if you add everything, you are getting about 74,000. And Bernard, the danger is that at the end of 2026, another 23,000 come and add. Hear me well. So we'll hit about 97,000. By the end of 2027, another 35,000 will come and add.
You are looking at those who are in school now?
Who are in school now? By the end of 2028, another 47,000 will come and add.
And this is all of these people together.
Exactly. If we leave this figure without doing anything about it, in the next 3 to 4 years, by the end of 2028, we'll have not less than 180,000 health professionals trained and they're at home.
Is there space for them? Is there work for them to do?
Yeah. You see, the truth of the matter is that you can only absorb what your budget can contain. It does not necessarily mean that there are no work in there. I mean, you go to some health facilities, we still need them.
So we need these guys, but we don't have money to pay them.
You cannot, absorb all of them. For example, we need 6 billion Ghana cedis for the health sector alone to be able to absorb the 74,000. So there should be a strategy. And I just want all of us to understand what we have come to meet and what will be coming. So that when we are solving the problem, everybody...
Sorry, can you go to... You are saying that from next year, how many more are joining?
So from next year, that is the end, by the end of 2027, by the end of 2026, we have additional 23,000.
Wow.
By the end of 2027, we have additional 35,000.
Wow.
By the end of 2028, we have about 47,000. So by the end of 2028, if you don't employ anybody, and this 74,000 is still outstanding, we will have not less than 180,000 health professionals trained and they will be at home.
So when will you employ these 74,000?
Okay, so there's a strategy going forward. What we are seeking to do now is that, of course, gradually, government will be employing some of them as we move along. We are also looking at what we call managed migration, how we'll be able to export some of them. It's another strategy.
You are going to export them?
Yes, that's what we are thinking about. Now, about 13 countries have responded. But the difficulty is that most of these countries that have responded, they need a specialist. You understand? And we don't have many of the specialists in the system. So the ministry is collaborating with University of Cape Coast, trying to get a curricula to be able to train more of the specialists. So instead of, let's say, 2 years, without compromising on quality, we want to have a crash program to be able to train more within 1 year so that they will meet the global standard and we can be able to export some of them whilst we maintain the optimal workforce we need as a country. Because even if we decide to fill all our health facilities with this optimal workforce, we'll still have some health professionals still at home.
So you are expecting about 180,000 health professionals by end of Mohammed's first term.
Yeah.
MPP began something called Agenda 111, which is essentially to build 111 hospitals. It appears as though this government is not interested in it.
We are very much interested, but what I can say for now is that we are auditing the whole process.
You're auditing what?
We are auditing the whole, from the civil works to the finances, how much has been paid, who has been paid what, work done. Then we understand what we have inherited and see the strategy we would apply.
How many of them were built before you took over?
Well, as at the time we took over, there were about 3 of them that were more than 80-90% complete. They were the ones that said they were in operation, but when we visited the site, they were not actually in operation.
As we speak, are any of the Agenda 111 hospitals in operation?
Not a single one of them.
You are sure?
Yes. They didn't.
So, but what was the highest percentage of completion?
That was around 80%, but I think the full report will come at the end of the audit. I don't want to preempt the audit.
Was any budgetary allocation made for Agenda 111 hospital in the ATU's first budget in March? Why not?
Because you have to understand what you are inheriting before you can budget for it.
They said they are building hospitals and they started the hospitals.
There is no dedicated sources of funding. And so they were only relying on GOG. And so if you want to go that route, you must understand what you have inherited. And
so when you get the full audit, what will you do with it?
So when we get a full audit, there's a strategy. What we're going to do is that those that are far advanced, government may want to continue. But
where far advanced means what?
Above 70% completion. And then those below 70% will bring the private sector in PPP.
Don't forget, NDPC told us that project delays cost overruns.
We will not delay them. Once the audit report is ready.
So what if a hospital in Joaboso is 20% complete? Will you abandon it?
No, we won't abandon any of them. What we are saying is that we'll bring, for example, churches that are interested in running hospitals. CHAC, with government partners with those institutions. We give them personnel and they run these health facilities. So we'll reach out to them, individuals, people who are interested.
So you are saying those who are above 70%, you use government of Ghana money to finish?
To continue.
And those below 70%, you will find a private sector partner?
Yes.
So if you don't find a private sector partner, what will you do?
We'll find.
From where?
We'll find in the country.
Has any private sector person
it doesn't also necessarily. It doesn't also.
Have you done any work to show that?
Yeah. A lot of them have even approached us, especially the churches. The Pentecost leadership have approached us. The CHAG.
But would this be district hospitals? Because the understanding I had was some of them are district hospitals.
Yeah.
Can district hospital be run by a religious organization?
Oh, some of them are doing far better. They already have some hospitals that are at the level of district hospitals.
Okay, there are some hospitals which have not finished. Outside Agenda 111, La General Hospital is always in the news.
Yeah.
What is happening to the hospital?
Yeah, so La General Hospital, in the 2025 budget, we've made an allocation for La General Hospital. So we've made allocation of not less than 130 million Ghana cedis for La General Hospital, and it's being processed for payment.
So when will work start?
I am very, very sure. Even as at the time I visited, they were still on site. So I know that very serious work will start maybe next week.
Okay, let's deal with a few other issues. NHIS is a perennial issue. The fund had been capped. What is the status of the health fund, the National Insurance Fund, number one? And number two, what is your report on regularity of payments?
Yeah, one of the reforms His Excellency John Dramani Mahama made in the health sector was to uncap the national health insurance when we took office. And so, for example, in 2024 National Health Insurance Formula, we call their budget formula. An allocation of 6 billion was made to the formula for expenditure. And in 2025, due to the uncapping, we were able to make an allocation of about 9.8, 9.9, almost 10 billion. So more revenue to the National Health Insurance Fund. But the most important thing is not even the allocation, because even if the allocation is made and there are no releases, you cannot spend. What it is at the moment is that we had witnessed a scenario or cases where even in some cases a whole year no release was made with respect to that particular year. But this time around, the good news is that there's prompt releases of fund into the National Health Insurance Fund. So now we are paying service providers monthly, every month. In fact, the allowable period of arrears should have been 3 months. But as I speak to you now, we'll pay them monthly. Any service provider we owe at the moment means that he has not submitted his claims. So there's prompt payment of claims, and that is why you don't hear these issues about service providers wanting to withdraw their services and all that. So the National Health Insurance, as we are managing today, is doing very, very, very well.
I'm going to read a few questions to you. We are going till 10:30 today, so we have a time for some questions from the public. Good evening, Bernard. As Health Minister, what is he doing to put an end to the sale of tramadol and other hard drugs in most parts of the country, since most of our youth are heavily addicted to these drugs? Abdul Mumin Wun Nam in Tamale. Can you address that in a
Yes, we have declared war against the importation of these opioids in our country. So we have increased surveillance on our borders. And what we have said is that apart from the port and the Kotika International Airport, no medications or medicines should come from any of our borders. Once we find out that any medications coming from one of our bodies is confiscated and destroyed. And so we have increased surveillance, and we have even confiscated some of them in recent times and destroyed them. So we are much interested in monitoring that space very, very well.
Another comment that came in is from Henry Sogakope. Good evening, Bernard. Please ask the Minister what plans he has for unemployed allied health professionals. Is that what you address?
Yes. So we are going to, every budget, I know government is going to give us some quota to recruit, and then we're also looking at how we can export some of them. And all.
So he's asking, can the Minister assure us publicly that all qualified allied health professionals will be posted?
Not all, please. I cannot assure you that all of you. We cannot put, 74,000 health professionals on the payroll next year.
He didn't ask for next year. He's saying, can the Minister assure us publicly that all qualified allied health professionals will be posted? And when would that happen?
So he's calling for when.
So
what we are going to do is that gradually, as and when we get the quota from the Minister of Finance, then depending on how much or how many the budget can accommodate, we will spread it equitably. We will give some to the nurses, midwives, pharmacists, allied health, all that.
Honourable Minister, in the resetting manifesto, there's a clear commitment to establish a medical lab council to enhance professional regulation, quality assurance, and the welfare of practitioners in the field. As someone who once served as the ranking member of the health committee and now leads the sector, what is your current position on this initiative? Specifically, how soon can stakeholders expect concrete steps towards making the council a reality to strengthen the standards and professional development in medical lab practice?
A committee has been constituted to look into those matters. In fact, yesterday I even met the leadership of allied health.
So, and what timeline are they working with?
Well, they will probably bring me the first report maybe in the next 3 weeks to 1 month.
There's a long one here. I heard the minister talk about the frequency and speed with which equipment break down in hospitals. I think it needs to put together a team of biomedical, mech, and electrical engineers to do a proper assessment and present the data. Much of the trouble may be coming from 1, erratic power surge by ECG system, 2, thunderstorms causing extreme power surges, and 3, inferior control board components. Some of these control board repairs can be done by regular electrical technicians in the communities who repair fans and TVs. That should be done first before suggesting that there's some kind of sabotage going on. We need to treat our healthcare workers with dignity and respect. There's no need being suspicious of them for every little thing that happens. I've operated a scientific laboratory for the past 17 years, and the high number of equipment I use have exhibited frequent breakdowns, but I can confidently rule out any human elements in the situation. So this is a long one. What's your comment?
Bernard, one of the difficulties we have in the health sector has to do with equipment. When we say a health facility is about the personnel, the equipment, that is the diagnostics, and maybe the infrastructure, the edifice, the building. But the last time we did major retooling in this country was around 2014. So when you go to most of our health facilities, we have obsolete equipment in our health facilities. We are doing our best, buying some of them, but Bernard, the truth be told, it's not sustainable for government to continue to buy these, medical equipment, and then 3, 4, 5 years later, you have to cost some money to go and replace them. It's not sustainable. Whilst we are looking at buying some of them, what we are thinking about at the moment is what we call hospital equipment placement. We are bringing the private sector in. So listen carefully. This is what we are going to do. Now, what we are proposing, and it's still at the preparation stage, anybody can come and then express an opinion or bring your ideas to fine-tune the policy we are bringing on board. What we are doing is that we will divide the whole country into lots, and then we invite the private sectors that may have some relationship with equipment manufacturers. So when you are giving health facility A, you provide all the equipment at the health facility A. Then the vendor will then train the health professionals how to use the equipment. Okay? When the equipment is faulty or obsolete, it is a responsibility of the vendor to replace or to fix the equipment. It is no more government responsibility. Now, the claims that are submitted to the National Health Insurance has 3 main components. 1, the medication. 2, the consulting or the services. And 3, diagnostics. In this case, the diagnosis will be taken out of the claims to be given to the vendor. So that it will not be government responsibility again to be buying equipment all the time. Once the private sector comes in and they are short of a sustainable way of funding, they will develop interest in safeguarding the equipment, and they will not have this issue of, oh, this equipment is not at this facility and all that. This is what we are proposing, and we are still at the stakeholders consultation level. So this is what we are bringing. And in fact, we have started with the dialysis machines. So we are looking at a similar approach when it comes to the dialysis machines. And Bernard, let me say that as a minister, from where I sit, I hear a lot and I see a lot, especially, reports of incidents. It isn't everything that I can put out there. There are a lot of things that happen, and we are not ruling anything out. It isn't everything I will say on this platform.
There are lots of comments coming for you. I'll take another break. This is the point of view. We're speaking to Kwabena Mintah Akandoh, and it seems like the health professionals have a whole bunch of things to ask you. We'll also speak about Mahama Cares and free dialysis. There's a challenge with H1N1 influenza. We're told that in some schools there's a concern that there could be a spread of all of those. We'll be discussing all of this when we come back. This is the point of view live with Kwabena Mintah Akandoh. Don't go away.
When malaria strikes your home, it strikes everything. Sleep, peace, and even work. Don't miss deadlines because of malaria. Don't lose your sleep to malaria. No more endless worry because of malaria.
Ole loco, enough!
Fight malaria back with Vegetem. Vegetem is effective, safe, and fast-acting against malaria. With its alu-alu packaging, Vegetem tablets stays effective right to the very last tablets. Vegetem is also available in suspension for children. Vegetem, tough on malaria, easy on you. If symptoms persist after 3 days, please consult a doctor. This advert is FDA approved.
Kwame and his uncle are almost here.
Wait a minute. This one too, your friend Kwame.
Wait, Kwame. As in the same Kwame again?
Yes, mommy.
I'm the second coming. Into all this tension just to reintroduce that broke boy from Kaswa.
Why would you deceive the family like this again?
Now I understand the whole delay. Troll from Kaswati. Why wouldn't he be late? Or be later?
Of course.
Star 712 hash, star 712 hash. You go feel the luckiest. Go feel from Georgia be luckiest. From not the cause she be luckiest. Yeah, you go feel be luckiest. No matter why you're luckiest. Everybody go feel be the luckiest.
That's Kwame!
Send your God the apple boom. If you put it toy, so would the coming of the son of man be. Is that his car?
Dial star 712 hash. Choose your ticket. Enter your lucky number. Follow the prompt and let destiny handle the rest.
This promotion is regulated by the NLA on the Caritas platform.
We're still here with Kwabena Mintah Akandoh. He's the Minister for Health, and lots of things have been said. We've discussed his style, visits to hospitals and announces it's not going to stop. We've discussed the backlog. We are told close to 75,000 health professionals. Some have been in abeyance since 2019, a lot since 2021. He can't tell me exactly when all will be employed. He says there's a plan. And this is all kinds of people. Some are pharmacists, some are medical lab,
health,
and all kinds
nursing.
of things. And apparently by 2028, if we don't employ these 74,000, we'll have 180,000 health professionals. But doesn't the private sector employ nurses? Why
They
does
do.
Why does government have to employ all these guys?
That's another question. But at the end of the day, I mean, government must create the environment.
So does it mean that health facilities, majority are owned by government?
The health facilities
Yes.
or the nursing training schools?
Health facilities that employ people, majority of them are government
Yes,
owned. For which reason you
majority-
employ a chunk of? It's like teachers.
Yeah. The majority of them are owned by we have, from the primary healthcare level alone, I think we have over 9,000 health facilities.
But why are you training our people and they're also leaving us? Doctors are leaving. I'm told the training of a medical practitioner, whether it's a doctor or nurse, is subsidized. You are telling me you are going to even send some away to other countries. But you go to many regions, there are no doctors. You go to many, in fact, if I go to your region of birth,
as for the medical
there's
doctors,
a paucity of medical doctors
as for the medical
in the rural
doctors,
areas.
No, for the medical doctors, we are not sending anybody away.
They are going on their own. You don't need to send them.
Of course,
And you can't
yes.
stop them. But you subsidize their training.
Yes. So
why are you subsidizing doctors' training and allowing them to go?
You can't, I mean, if you say
Give them
allowing
incentives. Give them incentives to stay.
You know, Bernard, one thing we must, as a minister, I would have wished that we will give every health professional what he or she wants. But we can only take from their budget. We can only take from
I
the
remember in the
coffers.
past, they
It's
were
not as though
helping
it is
them
there and we don't
acquire
want to.
cars
So,
at a cheaper rate or sort of tax-free or something like that. But I think somebody stopped it. Are you aware of this? Because some doctors complained in the past that it was difficult for them to bring in those cars or something as part of the package for them to feel incentivized to stay.
yeah, I mean, something of that nature was done last year. And then the interesting aspect was that they were promised that they were going to have tax waiver, properly so called. But that was not what happened. It was like whatever they imported was charged against the Ministry of Health, budget.
So it was deducted from your budget?
It was deducted from the ministry's budget. So it was not a tax waiver.
So who stopped
even
it?
when we took over as government, they had imported some of them. So I had to go to the Ministry of Finance, spoke to the Minister for Finance, so that we could clear all those cars that had already been imported. Some of them even went into demurrage. We had to also clear the demurrage and then give out their cars. So now we are looking at it. We are looking at how we can organize it well and give that kind of incentive to the health professionals. It's something that is on our
Because
table.
as a minister from a rural community by birth and training, and a deprived one at that, you should be concerned about the skewed distribution of doctors in particular.
I am very, very much concerned.
So what is your plan to ensure that doctors agree to go to underserved areas?
So we have an incentive where we are planning to define what we call underserved communities. Okay? I mean, there could be a facility in a city or urban area, but it may still be underserved. So we are defining what underserved community means and trying to come out with some kind of incentive like 20% of the basic salary for health professionals who accept postings to the rural areas. So these are some of the things. And then giving them promotion, earlier than those in the cities. And all. So there are a number of incentives we are planning.
More comments coming in. Good evening, Bernard. There's one Ajanawa One hospital in Deme, in Afajato South District, which, when completed, will serve the catchment area. Yes, value for money audit is necessary, but I will plead with him to take a second look at it due to the unavailability of health facility in that area. This is Jones Adoboy from La.
Yeah.
He's making a special case
for a particular facility. There are some districts without district hospital at all in the country. And we'll take...
Which is why I'm a bit concerned that you are saying 70% and above government will finish. Because if Deme is 20% complete, and they are not getting a private sector person because the hospital may not have the...
We'll give a special dispensation to those groups.
Yeah, so then I expect you to be a bit more nuanced, because you're saying it's 70%
yes,
and above.
that's the general, that's our general, that's the position. But then, districts where there are no district hospital at all, we could give some special dispensation and look.
There's a very long one here from Ernest Jiwonu, and I'm going to try and summarize it. It says, Bernard, medical lab professionals have had this problem and have complained not less than 3 occasions and even gone on strike over this particular matter. We must not wait for this innocent minister to make this catastrophic mistake by simply handing over the labs and its related equipment to a private entity. Or investors would mean the introduction of cash and carry. At the very beginning, they would deceitfully say it will be covered by the health insurance. Once the takeover is complete and the sick populace becomes dependent on this equipment, the Association of Hospital Lab Services Providers or private entities will come together and say that the tariffs as provided by the NHIS are not realistic, and so they have to receive top-up and introduce cash and carry. It's a long story. Basically, he's saying that...
So let me clear some...
let me try and understand the comment. So he's saying that... Okay, have you said you are handing over any labs to private operators?
No, that's not what I'm saying. So please get it clear. We are simply saying that the private, people or the vendors will put their equipment at the facilities. They are not the ones going to run it. They are not the ones going to employ these laboratory technicians or whatever. It is government that is going to. So as I told you, I met them yesterday and I explained some of these things to them. One of the concerns were the fact that if you give it to the private sector, then the private sector is the one going to do the recruitment, and it may hinder the recruitment of these professionals in the system. We've made it clear that all that the private sector is going to do is just to put the machine there. And again, even when we pay them, there will be another profit-sharing arrangement between the facility and the vendor. Okay? And then, in any agreement that we will sign, we are not going to allow them to charge their own fees and charges. The fees and charges will be subjected to Fees and Charges Act of Parliament. The fees and charges will be subjected to the tariffs of the National Health Insurance. These are all conditions.
Okay, he's suggesting that you should set up a hospital lab account similar to what happened between the 80s and the 90s to address shortage of medicines at the hospital in the form of revolving drug fund. This mechanism will ensure the abuse of drug funds should stop. The hospital lab account will completely solve the problem and pay for the services. So I don't know whether
this was my initial position when I took office, that they should ring-fence some money to fix the machines when they are faulty and all that. But you should be listening to the Public Account Committee, what they are even doing with this pharmacy accounts. You should be listening. You understand? And so if you decide to do that, what about the hospitals without the full complement of equipment? It will take government more than 10 years to be able to provide all the required equipment in every health facility. Okay. We don't have that money. And that is the truth. Maybe I'm being too frank.
All right.
So we have to bring the private sector in. If we go by this approach, what it means is that we can fill most of the hospitals at the same time, because the money may not come from government at the same time. But if we decide to wait, let government come buy all the equipment that we need in all the health facilities, we'll have a problem. But that notwithstanding, I'm open. If you have ideas, we can still further fine-tune it. But there will be profit-sharing arrangement between the vendor and the facility, the health facility. And then it is not as though it is the private sector that is going to manage or run the labs. No. The labs are just going to be run by the hospitals as they do. They are only going to put the machines there and keep their eyes on the machines. When the machine is faulty, there's an engineer on the standby to fix it. There's a group, engineers, to train the health professionals how to use the machines. This is what we are bringing.
Let's deal with free dialysis. You announced on Monday that the president has directed that government dialysis subsidy be extended to private health facilities. Just put a bit of flesh on this. So is this for all?
Yes. So at the moment, per the National Health Insurance tariff, dialysis per session is around approximately 500 Ghana cedis. So what we are saying is that not all the patients go to the public facilities, okay? So Bernard will go to a private facility, and the private facility will charge, let's say, 1,500 Ghana cedis per session. But government will then come in to pay that 500, will pay to anybody who goes to the government or public facility. So we'll pay that 500 for you. If it is 1,500, then you top up with 1,000. That's the policy we are going to roll out.
Beyond dialysis, there's concern about kidney and organ transplant generally.
Yes, that's another
How far have you gone with the legislation for kidney or organ transplants?
Yes, so we are still looking at, we are still at the consultation process. So we are evolving the policy, and after that, we'll go to, stakeholder consultation, we'll then go to cabinet for cabinet approval, then we'll go to parliament. So we are still at the stakeholder consultation level.
There's a pushback from somebody in the pharmaceutical sector when you said that NHIS, let me read this is from somebody from the pharmaceutical manufacturers. Bernard, the minister has not been truthful on the payment to NHIS, of NHIS to the facilities. Yeah, this is from somebody in the sector. So what did you say about payment? You said they are paid in a month.
Payment is prompt, and we are paying
prompt means
monthly.
What? For all types of facilities?
All service providers.
Does this include to pharmacies?
You see, pharmacies do not have direct relationship with national health insurance per se. Okay. It is a health facility like the hospital, and that is included. So when you bring your claims, it is part of what you submit to the national health insurance. And I can tell you, Bernard, I can tell you on authority, if your facility maybe hasn't brought their claims, then that's their own problem. Or if they say, and you see sometimes once a while, and that is even less than 10%, the system will skip a month or so. And even the practice is that 3 months arrears is allowable. And I'm saying that we don't even keep up to the 3 months arrears. We are paying monthly, promptly. And if he has any special challenge, I encourage him to come to the head office.
Good evening, Bernard. Tell the Minister of Health that all the sterilized machines at Kolebu Teaching Hospital are not working, and he should deal with it. There's no name attached to this message. Have you heard about this? All the sterilized machines. I don't know what you mean by that. Sterilization or sterilized machines.
I've not heard
at
about
Kolebu. Will you pay a surprise visit?
But if I announce it, it's no more surprise visit, Bernard.
Will you pay an announced visit? Please. Good evening, Bernard. Many institutions have stopped training physician assistants. Kindly ask the minister if it's government strategy to stop training physician assistants.
No. The answer is no. It's not government strategy to stop training physician assistants.
It's unjust to politicize the clearance of health professionals whose credentials expire prior to NDC's tenure and were absent in the transition notes. The current minister is committed and working tirelessly to resolve this issue, ensuring these professionals are absorbed properly. Let's support efforts to improve healthcare rather than politicize challenges for political gain. Mausi Ayebi, Abutia Teti. Bernard, I want to know if there are HPV vaccines available for women around 40 years. If yes, how do we access such facilities? Thank you.
Should I answer that?
Yes, I answer that one.
Okay, so HPV for now, according to statistics, about 3,000 new cases are recorded every year. And out of the 3,000, the mortality rate is around 2,000, very, very high. So government has adopted some approaches. So number one, cervical cancer or the cancers are part of the NCDs, the non-communicable diseases. And so what we are doing is that we've targeted girls aged 9 to 14. Yeah. And we are targeting 2.4 million girls. At the moment, we've been able to vaccinate about 1.8 million girls at the end of day 5. And we are determined to, do the mop-up to hit our 2.4 million. And then we are also trying to put machines to do screening, early detection. When you detect them early, it is curable and all that. And so we are trying.
So this human papilloma virus,
exactly,
cervical cancer.
Yes. So we are trying to put it now. We've installed, by the help of Telecell Group, we've installed a machine at Kolebu, one at Seviyoso, one at Tamale. We're expanding them for early detection, but we don't have vaccines for the aged or the 40 years group or whatever.
Minister, a seasonal influenza outbreak has been reported in parts of the country, with Eastern and Central region experiencing an outbreak of H1N1 influenza subtype. Reports also indicate that Greater Accra region is on high alert, with health authorities continuously monitoring the situation. We've already confirmed 42 cases of H3N2 influenza subtype. What is your briefing on this, and what intervention are you going to introduce to stem a full-blown outbreak of H1N1 or H3N2? I suspect this is bird flu.
Yeah, it's unfortunate, but it's normal. It's seasonal, as you have indicated. And so around the cooler months, we get some of these outbreaks. And so at the moment, the Ministry of Health through Ghana Health Service, they are coordinating with the various schools. It's very pronounced at where there's overcrowding. And so we are providing hand sanitizers. We are sensitizing people as and when you feel your throat is itching you are feverish and all that, you report to the nearest hospital. So the Ghana Health Service is collaborating with areas that we have detected this, flu and monitoring. So far, we don't have any critically ill person who has been admitted. And so we are on top of it. There's no cause for alarm.
Somebody wants me to ask you what you are doing about staff who divert government money into their private pockets. Some of these staff undercharge clients and pocket the money. Urgent actions need to be taken. Ntifafa from Aflao is asking this question.
Once you divert the state money into your coffers, it's criminal and you'll be prosecuted. Anytime we find such issues, the law takes its own course. The law takes its own course.
Bernard, your guest is presenting the data as if no one is retiring. How many retire a year? Over 80% of doctors in Ghana are in our teaching hospitals. Unless he's able to decentralize specialist training, move them to the regions, we are not going anywhere. This is a doctor saying that the reason they are in the teaching hospitals, obviously, is because they lecture as well. And so it's almost like it's not a question of just giving them cars or whatever. If training is not decentralized, you are not able. Do you understand? If if I'm a specialist,
yes.
I will have to be in Kolebu or UGMC or
as part of the Mahama Care. Maybe let me tie in with the Mahama Care. As part of the Mahama Care, there are some gaps. The specialists we need to treat these non-communicable diseases, we have a huge gap. So we are looking at decentralizing the training of specialists in this country. And by the beginning of 2026, we are starting 3 new regions. I think Wa, Ho or Hohoi, and then Boga. These 3 hospitals we are going to decentralize. So we will gradually decentralize the training of these specialists in some of our regional hospitals. So it's something, and it's one of the mandates of the Mahama Cares to be able to fund that particular training to fill that gap.
President Mahama hosted a health summit in Accra sometime a couple of months back. I think it was the African Health Sovereignty. And it appears there are efforts to raise more financing for doing a lot of things. Can you give us an overview of that? Is it to say we are going to depend less on donor support? Africans must come together to provide money for their healthcare financing? It was a health financing conference at which you spoke. What was the big plan for that?
Well, His Excellency John Dramani Mahama is so committed to the health sector, and he's leading something on the continent that we must take our destiny into our own hands. And therefore, we are encouraging all African countries to up their domestic mobilization of resources when it comes to the health sector. That is a summary of it. So, for example, we have the national health insurance. Some countries don't. We have brought Mahama Cares. So these are all domestic mobilization of resources. And when you have this domestic mobilization of these resources, nobody anywhere would dictate to you how to use that money. You apply the money where it is needed most. But when it is a partner or, somebody bringing you the money, it comes with strings. And what His Excellency John Dramani Mahama is saying is that the resetting agenda or the sovereignty doesn't mean isolation. It doesn't mean we don't need partnership. We need partnership, but what we are saying is that the partnership we need must make sense. And every partnership we need must be country-led. We must lead those policies. We know what we need most, okay? And so, 1, it's about domestic mobilization. 2, it's about using the resources you mobilize where it is needed most. 3, it's about partnerships that make sense. In the health sector, for example, we have about 3 main priority areas. 1 is how to make Ghana a pharmaceutical hub. You realize that during the COVID pandemic, we suffered before we even had vaccines. Countries looked into our eyes and told us, look, we're not going to give you vaccines until and unless we finish vaccinating our citizens. So we've learned from that. And we are going to exit Gavi. Gavi is, they help us to procure most of our vaccines and all that. So there's a clear plan to produce vaccines in this country and to up the percentage of production of pharmaceutical products in this country. It's a priority area. And then the second one is how we can tackle the non-communicable diseases. The non-communicable diseases constitute not less than 40 to 45% of our mortality rates. So how do we handle that? we have two approaches there. One, free primary health care. Free primary health care, in order to quicken our journey or our steps towards the universal health coverage. Free primary health care, in order to increase screening to detect those conditions on time, to be able to avoid its complications. Free primary health care. Free primary health care, in order to erase the cost that hinders the progress of universal health coverage. Now, Mahama case. This Mahama care is dedicated towards the funding of these non-communicable diseases. Because you realize that when people have these complications, hypertension, diabetes, and what have you, it draws them into poverty. They don't have the money to fund it, the cancers and what have you.
Okay.
You understand? And so these are some of the policies that dovetails into the health, sovereignty, the resetting agenda.
A couple more issues to do, and thank you for staying. I know it's been a long day for all of us. The nurses, and this is not new nurses, this is old nurses. In June, they declared a strike or threatened a strike over conditions of service. You gave them some commitments, but we've seen some agitations in October. NLAC has also said some of the actions have been illegal. I think this has to do with their conditions of service and allowances. What is the update on?
So now it is one of the conditions of service that was signed and never implemented when we took office. So out of those conditions of service, what I can report now is that fortunately we are now implementing 2 out of the items they are demanding, and we are still in talk with them to make sure that the rest are implemented.
2 out of how many?
I think 2 out of 6.
When was the last time you engaged them?
The last time we engaged them was more than a month ago. By the last meeting they had was with the Fair Wages and Salaries Commission, yeah.
There is an Mpox outbreak we've been battling with. The numbers keep rising slightly. What is the update? Is there a vaccine yet for Mpox?
Yeah. So the update is that we have about 730 new cases for now cumulatively, and we have secured vaccines, and we are targeting about 19,000 people to be vaccinated. There are some areas that are more endemic, and so we are targeting about 19,000. So far, we've vaccinated 15,000 people, so 4,000 more to go. 2 deaths.
It seems to me as if healthcare in Ghana is sickness care. We are always talking about medicine, vaccine. What is your plan for health prevention and public health education? Because almost like every time, let's buy medicine, let's buy equipment, let's buy drugs. But there's something to be said for people not falling sick and also behavior.
Fantastic.
What's your plan for that?
So the free primary health care will give real meaning to the preventive. So people will come and measure your BP. You will go to the hospital not only when you are sick to know your sugar level. You understand? Screening, early detection of these complications. They are all going to be part of the package with the free primary health care. Okay, how we exercise, how our chip compounds will send the healthcare delivery to the doorstep of the people, educate people, sensitizing people, how we can get airtime on the various radio stations, the information centers, to be able to educate people. They are all part of the package of the free primary health care. Yeah.
Let's talk about your constituency. So, you are from Joabuso, I see. What is your region, one of the poorest in the country, basically, the Western North. It's a new region. It was split from the Western region.
Did you say it's the poorest?
One of the.
It's not in my region. I disagree with you. My region is not poor.
Oh, okay.
If you say it's one of the new regions,
okay, I thought it was a deprived region.
It could be deprived.
And you are the only cabinet minister from the region?
Yes.
From
for now.
I see. So Samson Ahi is deputy
minister for agribusiness, trade and industry.
I see. Is Galamsey taking place in your region?
Galamsey is my region. It's my district. It's my constituency.
How concerned are you about that?
Very, very, very much concerned.
Somebody says we should declare Galamsey also as a public health emergency because of the effect it has on people's health, chemicals in food and water. Is this something worth considering?
I think we will take the approach we are taking at the moment, trying to clamp down on the galamsey, educating the people, bringing everybody on board to fight it, and I believe that we'll all succeed. It's a major concern, especially to the health professionals, because the impact of galamsey to our health. Do you know it's one of the causes of the NCDs?
The non-communicable diseases?
Yes. The cancer, sometimes you give birth to babies with deformities. It's as a result of this, galamseys. So it's a major concern.
Can you lead a public education campaign in your region about the health effects?
Yeah.
It is and should the Ministry of Health play a more frontal role? I hear doctors talk. I don't hear the ministry issue statements on galamsey.
I agree. It is something we are considering. We want to, you see, this is inter-ministerial to tackle this fight and to be successful. So it is something we are considering to also help in the fight against galamsey, the sensitization from the CHIPS compound to the health centers. So you see, these people live with the people in the various communities. That is how decentralized the health system is. So it's something that we are designing to charge our people to also go out
because
there.
Because there's a public education component of galamsey. In some communities, the people actually don't see anything wrong with mining in water bodies. And they say it's their gold. The mining companies have come, they haven't gotten anything. So there's a lot of public support in some communities for galamsey.
Yeah, it's true. In some communities, when you even go, fighting galamsey, they get these galamseys and hide them in their rooms. They protect them.
They protect the galamseys?
Yes, they do. I'm coming from a mining constituency, so I know what happens. And so it's something we are planning to do. We are looking at how we can even get, in the rural areas, how we can get airtime on the various radio stations, the information centers, and try to educate people, reach out to the people in their mosque, churches, to talk about these things. So it's something we are considering very well.
Will Muhammad solve the galamsey problem?
Why not?
Because it doesn't look that way. A lot of people are unhappy with the pace of work.
I am very, very, very confident that we will make a great difference. But you see, when you start a new government, you always have challenges. You will always have challenges, especially issues like galamsey. It's not an easy fight, but we are determined to fight it. And the health ministry will come on board strongly. Yeah.
What's your message to your constituents as we close?
Well, I just left my constituency, and by the grace of God, I commissioned a sports complex for them. I started somewhere last year, and they played a first division match on Sunday before I even left to Accra. And so,
is there a first division team in your hometown?
Yes, Sefi All Stars.
Sefi All Stars,
yes.
Division 1?
Division 1.
So you build a sports complex for them?
Yes, a sports complex for them.
I see.
It's not AstroTurf. This is a solid sports
proper grass.
A proper grass, and then inner perimeter.
What capacity
dressing
stadium?
Room. I think it should be able to take more than 5 to 10,000, between 5 to 10,000 people.
Wow.
Yeah, between 5 to 10,000.
So there's a Division 1 team in your hometown?
Yes, there's Division Sefi All Stars. So we are determined to continue the building of the chip compounds in my district. We are determined to do the roads, connect to the rural.
Do you still get time to farm?
Yes, I farm, but I don't get the time as I used to.
What do you farm?
I farm rice, from farming to processing to distribution, the full chain.
How long have you been farming?
I've been farming commercially. I've been farming since 2013, 2014, commercially.
You're a commercial farmer?
Yes, I'm a commercial. Arguably, I'll be one of the biggest rice farmers in this country.
Will you enter the Best Farmer Awards?
No, for now.
Or you are politically exposed?
because of the work I'm doing at the moment, I have laid the cutlasses and what have you down for now. But people are...
There's a lot of questions for you. We don't have time, but the truth is that your sector has many issues. We thank you for speaking to us. We wish you well in your efforts to try and solve some of these problems. We've been speaking to Kwabena Mintah Akandoh. He's
That's
a
all
health
time
minister.
can allow us.
Yes.
Okay, thank you. I thought you had more questions and you had more time.
I have a morning show tomorrow. So
Bernard Avle, we're going.
I have to be on the radio in the morning. So
that's on a lighter note.
We will invite you to come back maybe.
There are a lot of problems.
Next,
and you see,
next quarter
the
or something.
public interest in the health sector is very, very high. Understandably so.
I see.
Because the survival of the citizens in the country depends on that sector. And even some way, somehow, it has some direct correlation with the productivity of the country. So everybody's in it. So the slightest thing drop in the ministry, everybody gets to know and everybody wants to follow it religiously.
Yeah. You have a very active population of nurses and doctors who express themselves. We
Yes,
wish you
yes.
well in handling them. Thank you. That was Kwabena Mintah Akandoh speaking to us on The Point of View. We'll see you next time. Good night.